What I'm going to be talking about today is the prevention of bronchopulmonary dysplasia, or BPD, which is also called chronic lung disease of prematurity, or CLD. Most people use those terms interchangeably. We have a small group, and it's Casual Friday, so we can take it slow. My main purpose is for you to learn and hopefully retain some of this information. So again, what we're going to be talking about is the prevention of BPD, not the treatment of BPD. So I know some of you are anxious about some of the patients that we have in the unit that have severe BPD and would like to just jump right in and start talking about those patients. But before you run, you need to learn how to walk. And so that is really the point of this talk. And it's really about 4 hours worth of information. So that's why I divided it into 2 portions. And again, we can go slow. A lot of these concepts are very basic, fundamental concepts that any person taking care of a ventilated patient, whether it even adult patients, needs to know. So if you were a resident or a fellow and you didn't understand a lot of these concepts, you are not going to be successful taking care of your patients. And I would impart that onto neonatal nurses as well. So hopefully you can see the mouse. You guys see this mouse? Okay. So on this slide, the normal slide, this is a pathologic slide of what is normal lung parenchyma. And you can see how thin the alveolar capillary membrane is, and how all these little alveoli are kind of hexagonal or polygonal. Lots of air for gas exchange. So this is what a normal lung should look like. Contrasted with a pathologic slide of an infant with BPD, you can see that the alveoli are smoother, they're less hexagonal or polygonal. Here's some blood vessels right here. This is the muscular wall. It's hypertrophied on these blood vessels. The interstitium is thickened, and there's lots of these tiny little purple dots. Those are inflammatory cells. So you can imagine if a baby had this lung architecture, it'd be much easier to exchange oxygen and carbon dioxide compared with trying to diffuse, this would be the inside of the blood vessel here and here, trying to diffuse oxygen and carbon dioxide from inside that blood vessel to the alveolus would be much more difficult. So that's kind of what we're dealing with at the microscopic level. So the objectives of this talk, again, primarily to learn, but I'm going to review strategies used to prevent the development of BPD, discuss some basic concepts of conventional mechanical ventilation, and also discuss some basic concepts of non-invasive ventilation. And some of this, depending on how far along we get, may be in part 2 of the talk, which I think is in December 3rd. So why do I have this slide here? It's not to be sarcastic, but when we talk in clinical settings, in the NICU, in the delivery room, wherever it may be, we often think that we're all on the same page and speaking the same language. And in some cases we might be, in some cases we think we are, but it's really important that we are all on the same page. And so I want to try to very carefully define and explain some of the terms as we go through this talk, and I want things to hopefully be crystal clear. I'll give you an example of a non-respiratory term. So a lot of the time we'll say on rounds, well, baby's on TPN, total parenteral nutrition. In reality, the only time you're on total parenteral nutrition is if you're NPO and 100% of your nutrition is getting infused through your veins, right? So most of the patients we take care of in the NICU are actually on just PN, parenteral nutrition, and some enteral nutrition. So even though we go, oh yeah, he's on TPN. Well, if you wanted to be really technical about it, most of the time they're just on PN. Now we say that all the time, and that's okay as long as we all have awareness that they're not really on all parenteral nutrition, right? So it's a subtlety, and I'm not going to stop middle of rounds and correct you every time and go, well, really, the baby's just on PN, not TPN. Because you would want to smack me, and you go, okay, yeah, we know. And if everyone understands that what we're talking about, that's okay. But you can imagine if you're really picky, that might be confusing. And so it is important to be specific about terms. So what is BPD? Bronchopulmonary dysplasia is a chronic lung disease most commonly seen in premature infants who required mechanical ventilation and oxygen therapy for acute respiratory distress syndrome, but can also occur in neonates that have had a less severe respiratory course. So this definition is very specific. Not all babies that develop BPD were on a ventilator, right? Some of them were just on nasal CPAP. So you don't have to be intubated and on a ventilator to develop BPD. And some of them have not that impressive of a respiratory course. Certainly some of the babies are on lots of oxygen in high ventilator settings. But you've probably imagined, if you think back within the last year within our unit or your own unit, that there might be some babies that were just on nasal CPAP and not a whole lot of oxygen, and they were never really that sick from a lung standpoint, but they just lingered on, and they continued to need respiratory support, whether it be CPAP or low flow. They may have even gone home on it. So babies with BPD can be those that have a much more mild course. They don't have to be the sickest of the sick necessarily. So here's an x-ray of an infant with BPD. Do you guys see anything wrong with this x-ray? Oh yeah, so our respiratory therapist, the tube's high. So if you draw a line across the clavicles, a lot of people would define that as the thoracic inlet. Your endotracheal tube should be below, the tip of it should be below the thoracic inlet, probably right around at T2, right about there. So yeah, the tube's too high. This is a PICC line in the right arm that looks in decent position. This feeding tube looks too high. That should be inserted. So those are all things that are wrong, but mainly I was trying to focus on the lungs. So these lungs look awful, okay? So the lungs are hyperinflated. The diaphragms are flat down here at the bottom. There's patchy areas of atelectasis, this white stuff. And then there's also areas where it's much darker here and here. So areas of overinflation. There's lots of scarring as well, which is, if you look at some of these, white lines. So there's, this is not a homogeneous lung, okay? Lots of areas of scarring, overinflation, atelectasis, very damaged lung. So another way to define bronchopulmonary dysplasia is the need for assisted ventilation and or supplemental oxygen at 36 weeks post-menstrual age. It's the most common severe complication of prematurity. And the definition gets a little confusing the younger you are, because this disease was first defined in 1967, before surfactant, before antenatal steroids, before even neonatal ventilation was a thing, certainly before oscillators. And the disease has changed as medical breakthroughs have changed it. Okay, so things like antenatal steroids, surfactant, have changed what the disease looks like now. So Dr. Northway described it in 1967, and at that time he described it as lung disease resulting from prolonged mechanical ventilation in premature infants with surfactant deficiency. Because pretty much all the babies at that time had to be on ventilators and were very sick. They were also much bigger, older babies than we take care of now. Now we have NICHD criteria And they basically have this complex definition, which is down here, based on the baby's gestational age and severity of disease. So in order to define and diagnose BPD, you need to use this table, and you first have to know the baby's gestational age at birth. And they have a cutoff. Was the baby less than 32 weeks, or was the baby greater than 32 weeks at birth? And then you have to look at what point you're assessing the baby, and then you can subcategorize them as having mild, moderate, or severe BPD. So on the less than 32 week infants, if you have a baby who is born at less than 32 weeks gestational age, when they reach 36 weeks corrected age or discharged to home, whichever comes first, then you have to look at what their oxygen requirement is. So if they've weaned off oxygen, then they have mild BPD. If they're less than 30% oxygen, they basically have moderate, and if they're over 30%, severe. So it's a little more complex if you have a baby born at greater than 32 weeks of gestation, because you don't want to give that baby a diagnosis of BPD necessarily if they're exactly at 36 weeks corrected age. So for example, let's say you had a baby who was on oxygen for 3 weeks, born at 32 weeks of age, but then weaned through marrow. You wouldn't give them a diagnosis of BPD. However, if they were on oxygen at 5 weeks corrected age, you would. And so that's why this time point of assessment gets to be important. So if you're born if you're born over 32 weeks of gestation, then you have to assess the baby at greater than 28 days of life, but less than 56 days. And then you ask the question, are they on oxygen still? And if so, how much? So I'm not trying to belabor this point, but just to illustrate, it gets complex and specific in terms of how you diagnose BPD. So again, it's based on gestational age and then how much oxygen the baby's needing. That helps qualify it as mild, moderate, or severe. So why do we care? Well, mortality among very low birth weight infants or infants with birth weights less than 1,500 grams has decreased over the last couple of decades, but the incidence of BPD has not decreased. In some studies, they even argue that it may have increased. In surviving infants, so babies less than 28 weeks of gestation, the incidence of BPD is about 40%. Incidence increases with decreasing gestational age and decreasing birth weight. Babies that are higher risk are those that have growth restriction, male sex, and then certain fetal exposures, notably chorioamnionitis and nicotine exposure. So old versus new BPD. We briefly touched on this in the previous slides, and note at the bottom there's pretty considerable overlap with these two types of BPD. And again, the reason that we have these two different types of BPD is because with medical advancements, we've changed the natural history of the disease, how it looks on x-ray, how the babies look at discharge. But in the olden days, in the 60s, 70s, and 80s, it was associated with mechanical ventilation. They were large, moderate, and late preterm babies. The lung had a lot of fibrosis, increased interstitium, like I showed you on that very first slide, alterations in the airways. There were components of reactive airway disease. And this type of BPD does still occur, so you will still see this in some of our patients. The new BPD is more typically has arrested lung development with simplified lung architecture. There's abnormal abnormal growth of the lung vasculature. And these infants that get it are much smaller, more immature babies than in the past, like were in the 70s and 80s and early 90s. And most of these babies now have received antenatal steroids and surfactant. Long-term outcomes with BPD. It's the most prevalent long-term morbidity in surviving extremely preterm infants. During the first year of life, about half of these babies will require a rehospitalization. The incidence of sudden infant death syndrome is about 7 times higher. The babies that go home have increased risk of reactive airway disease or asthma, respiratory infections, pulmonary hypertension, postnatal mortality, so they may die, and the ones that survive are also at higher risk for adverse neurodevelopmental outcomes. So these kids are the smallest kids that are at risk for long-term problems. That's long story short as to why we are so concerned about BPD in the NICU. This is my main soapbox political slide. I'll try to refrain from being too political, but this is a very important slide that I recently saw in another talk, and probably will include in every talk I give in medicine from here on out. And it has to do with the social determinants of health, and I mainly just wanted to preach to you about this topic. So there are lots of things that influence health outcomes that we do in America. Health outcomes mainly being defined as how long we live and the quality of the life that we live. If you look at clinical care, so that's what we do as healthcare providers, it really only has about 20% of the influence. So clinical care includes not only quality of care, but also access to care. So access to care is one of the things that was improved by the Affordable Care Act. Quality of care is something that we're constantly trying to improve all the time and should always continue, here moving forward. But there's all these other things that influence health. Healthy behaviors, whether or not you smoke, what your diet and exercise are, alcohol and drug use. Social and economic factors, 40% of health outcomes are determined by social and economic factors. Things like education. Do you have a job? Do you have a good family support structure? What's your community like? Oh yeah, and then their physical environment, air and water quality, housing and transit. So when you look at politicians that don't want to support clean air and healthy water, that's ludicrous. One of the top, probably the main medical breakthrough in the history of humankind is the ability to have clean drinking water. Just ask the people in Flint, Michigan. So the point of this slide is that what we do in clinical medicine is a very small part of what impacts overall health outcomes. So I'm not trying to depress you, but just realize there's a lot of things that impact outcomes of the babies we take care of beyond what we do in the NICU. So what causes BPD? This is a common phrase that comes up in the literature. Oxygen plus volume plus time. So oxygen plus volume plus time. It's actually a lot more complex than that, but if you want to fall asleep now, you can remember that phrase. So in the setting of prematurity, there's all these other factors that influence the development of bronchopulmonary dysplasia. It's what you call a multifactorial disease. So things like whether or not the baby got antenatal steroids, there's certainly a genetic predisposition. What did the mother's nutritional status look like? Did the baby have a large patent ductus arteriosus? How much oxygen toxicity did they have? What was the ventilator-induced lung injury that the baby was exposed to? Did the baby get sepsis or necrotizing enterocolitis or have some sort of infection and release inflammatory cytokines that impacted the lung? And then what was the baby's airway disease or pulmonary vascular disease? So there's all of these different factors that influence whether or not a baby develops BPD. The other important thing to consider is the baby's stage of lung development. So in the 60s and 70s, the babies that survived and had BPD were born at a much different time in their fetal development, so their lungs were more developed. So if you look at this middle, these are the stages of lung development. There's actually two missing. Ahead of this should be the embryonic phase and the pseudoglandular phase, but those are prior to 16 weeks, so we're not going to talk about them. But so we have the canalicular stage, the saccular stage, and the alveolar stage. And so the old BPD, those babies were born at about 32 weeks and beyond. So they weren't even, able to stay alive in the 70s and 80s back then. But now we have kids that are being born in this saccular stage of lung development. And so that's why you see the new BPD down here. So this type of BPD is more typically has arrest of lung development or delay of lung development. And so there's all these other exposures that we talked about, whether or not the mother got steroids or had chorioamnionitis, did the baby have growth restriction? And then if you happen to have these antenatal exposures and you are born prematurely, then you're at risk for BPD. And then there's all these other things that can happen to you while you're in the NICU that we talked about, infections, whether or not you had pulmonary edema, what was the nutrition like. So what's the point of this slide? Well, there are some things that we can't control that influence whether or not the baby's going to have BPD before they get to the NICU. So these are some of the different things that we try to do to prevent BPD. Well, you can try to prevent prematurity. We can give the mother antenatal steroids. We're going to go through each of these a little bit in more detail. We can give surfactant. We can try to be gentle and very skilled when we mechanically ventilate the baby by using low amounts of oxygen if we can, trying to use non-invasive ventilation, using permissive hypercapnia. Some people advocate for volume-targeted ventilation. We try to be very wise and judicious about how we use antibiotics and steroids, optimize nutrition, caffeine, vitamin A. There are others that aren't on this list, but those are the primary ones. And then trying to prevent or minimize those exposures that we talked about on this slide. So infections on here, we want to try to prevent infections. So why do we have NICU nurses doing these bundled activities when you change lines and fluids? It's to try to prevent infection. There's a reason behind doing what you do. Genetics, we know through twin studies that there is a genetic component to the development of BPD, and maybe in the NICU of the future there will be some genetic testing at birth if you're at high risk, and we'll be able to subcategorize you and say you're at X risk. I don't know, but I imagine that kind of thing will happen, maybe not in my lifetime, but perhaps in the future. Preventing prematurity, that's what the March of Dimes major mission is now. So they spend millions and millions of dollars trying to prevent prematurity, and there have been some breakthroughs. If you have had a preterm birth now, you're often started on 17-OHP with your subsequent pregnancy to try to prevent a second preterm delivery. Antenatal steroids. We give antenatal steroids very specifically to women at risk for preterm birth. We primarily use betamethasone, although dexamethasone can also be used. And the way we typically give this is from the American College of Obstetrics and Gynecology, is we give a single course to pregnant women between 23 and 0.7 and 36 and 6/7. And this, I don't know if you recall, but this 36 and 6/7 is a recent development. Until about 3 or 4 years ago, it was only up to 34 weeks. So now we do up to 36 and 6/7 weeks of gestation who are at risk for preterm delivery within 7 days, including those with ruptured membranes and multiple gestations. The next line speaks to the rescue or repeat course of steroids. So when you give those, a single repeat course of steroids should be considered in women who are less than 34 and 0, who are at risk of preterm delivery within 7 days, and whose prior course was administered more than 14 days previously. Rescue course corticosteroids may be provided as early as 7 days from the prior dose if indicated by a clinical scenario. So they give you a little bit of wiggle room there. So what we don't do is give them every week. And that was done long ago. I don't know the exact decade. I think it was the 70s or 80s. So when people gave weekly steroids to mothers at risk for preterm delivery, it did bad things like decrease the baby's growth and brain volume. So that's why we give one dose followed by perhaps a rescue dose. We're trying to reach that happy spot where the benefits still outweigh the risks. And what I tell mothers, because they ask me this all the time when I'm speaking to them in L&D before their babies are born, they say, well, what do those steroids really do? Well, they do 4 things. They decrease the severity, frequency, or both of RDS, IVH, intraventricular hemorrhage, neck, and death. So those are pretty powerful outcomes. So that's what I tell them. I say those steroids help with 4 things. What about surfactant and intubation? These sentences are worded very specifically. So prophylactic intubation and surfactant administration versus CPAP alone does not reduce BPD. In fact, it may increase the risk. So don't intubate unless you need to. If you have to intubate, give surfactant early, meaning less than 2 hours after birth. That does reduce BPD if you compare it to giving surfactant after 2 hours. What about Ensure? So Ensure, which is intubation, surfactant administration, and then rapid extubation, usually after a couple of minutes, does not reduce BPD compared to stabilization on CPAP alone. So those are very specifically worded sentences, and they can be easily confused. So just keep those clear. Now we're going to move on to what I want to call mechanical ventilation 101. So does anyone know what the biochemical definition of RDS is? Respiratory distress syndrome, or hyaline membrane disease. So it's basically a disease of surfactant deficiency. What about the functional definition? The functional definition of respiratory distress syndrome is a disease of decreased lung compliance. So this is supposed to represent severe respiratory distress syndrome. I like to say surfactant deficiency because it tells you really what the disease is. It's surfactant deficiency. But you may also hear it called hyaline membrane disease. That's going back to the early studying of the disease when on pathologic slides the alveoli had hyaline membranes in them, so they called it hyaline membrane disease. So the classic hallmarks on a chest x-ray: ground glass appearance of the lung parenchyma, air bronchograms, and underinflation. So air bronchograms are basically, if you imagine the lung tree and there being air inside the branches of the tree with collapsed alveoli around them, you can kind of see the dark lung tree outlined. That's what an air bronchogram is. So this slide is just to show you that as you have decreasing gestational age, the incidence of respiratory distress syndrome increases. But look at these AGA babies here, this dark line. It's still not 100% even at 24 weeks. So there are some kids that are very premature, who are born and don't need surfactant necessarily. Now, they may still need respiratory support because there's lots of other things that influence whether or not you can breathe on your own besides just surfactant deficiency, right? There's the compliance of your chest wall. There's how floppy your airway is. There's control of your breathing from brain immaturity, right? So there's lots of other factors that would cause an infant to need respiratory support. And there's lots of other reasons that we might ventilate an infant beyond just respiratory distress syndrome. So other things that preemies have that cause them to need mechanical ventilation: apnea prematurity, pulmonary insufficiency, neck, tracheomalacia, whether or not the mom got a lot of mag and the baby has hypermagnesemia, analgesics, pulmonary edema, sometimes they go to surgery. So lots of reasons for babies to need respiratory assistance. So how does CPAP work? It increases FRC, functional residual capacity. It also helps prevent atelectasis. So when we say, this is back to that slide where we had the guy painting, the house, the dog. I want to make sure you guys understand what we really mean when we say functional residual capacity. So as all of us are sitting in the room right now, we're breathing comfortably. Inhalation, exhalation, inhalation, exhalation. That's your tidal volume. If you, with a normal breath, then tried to exhale out everything you could, that exhalation is your expiratory reserve volume. Now, there would still be some space in your lung, even if you tried to exhale as much as you possibly could. That's your residual volume. If you were breathing normally and then took a big inhalation in, that's your inspiratory reserve volume. So functional residual capacity is basically all the lung volume that's left after tidal volume. So it's your expiratory reserve volume plus your residual volume. So that's what CPAP or PEEP or descending pressure, I use those terms sort of synonymously, even though they're slightly different. Those are aimed at increasing your functional residual capacity, which is, again, this box in red. So what is compliance? Compliance is the change in lung volume over the change in pressure. So what does that mean? So a normal lung, all of us sitting here have a lung compliance of 0.003 to 0.006 liters per centimeter of water pressure. So what about a baby with RDS? They have low lung compliance, high lung compliance. So they have low lung compliance. So their lung compliance is much less. So what does that mean on a pressure volume loop? So this is a normal lung inhalation, exhalation. If you took the slope of this breath, the slope is compliance. So the change in volume over the change in pressure, that's compliance. So a baby with RDS is less compliant. So their slope, the change in pressure over the change in volume, is less. So another way to think about it is, what happens if you kept the pressure constant? What would the two lungs do in terms of their change in volume? Well, for a normal lung, you would have a change in volume of this delta here. Okay. You can see for the same pressure, the baby with RDS has a much lower or much smaller change in lung volume. Okay? You can look at the other way. What if you hold the volume constant? Okay, what happens? Well, you need a lot more pressure to get the same volume for a baby with RDS compared to the baby with normal lungs. Does that make sense? So these are fundamental concepts that you have to understand if we're going to be on the same page and we don't have to be painting the dog and the garage and the house. What's resistance? So resistance to airflow is the change in pressure over the change in flow. So normal lungs have, and I'll confess I don't have these units memorized for resistance and compliance. 20 to 40 centimeters of water pressure per liter per second is normal resistance. What about a baby with RDS? No change. What if we put a breathing tube in that baby? Much higher. We're going to talk about why that is. So when we put an endotracheal tube in any patient, we massively increase the resistance to airflow. So we're going to go through some mathematical laws, physics laws, and I'm not trying to put everyone to sleep, but these are actually important and applicable to your patients that you take care of every day. So that's why we're going to go through them. So the first one is, I'm not French, but Poussin's law, and this deals with flow of gas or fluid through a tube. The resistance of flow, R, is proportional to 8 times the viscosity of the inspired gas times L, which is the length of the airway, over pi times the radius of the airway to the 4th power. Well, this is highly important. We're going to go through this example. So you have an infant with a 4 millimeter diameter airway. Let's say the baby gets some airway edema, and you decrease it by, or let's say 4 millimeters, just for the ease of conversation, is the radius. So let's say we decrease the radius from 4 to 2, so a 2 millimeter change. Or wait, I'm sorry, they're saying it's diameter. So diameter decreases by half. You decrease the diameter by 50%. When you do the math, that's a 16-time increase in the airway resistance. If you're an adult, that same 2 millimeter decrease ends up only being a 25% decrease in diameter and only a 3 times increase in resistance. So either way, whether you're an adult or a baby, that making the tube narrower increases the resistance of airflow. If your tube's smaller to start with and you make it narrower, it's even a more massive increase in resistance because it's the radius to the 4th power. So this is why it's a big deal when we have a baby with a 2.5 endotracheal tube to go up to a 3.0 endotracheal tube. It's half a centimeter, but it's a massive change in resistance. The other thing to keep in mind is this L, this length of the airway. You may see the respiratory therapist sometimes will cut the endotracheal tube and shorten it because the length of the tube also increases the resistance. So the shorter tube, less airway resistance. What about time constants? Many of you may not be familiar with the term time constant, but it gets really important, especially if we ever get to the point where we talk about the kids with severe BPD. The time constant gets really important. So what is a time constant? So a time constant mathematically is resistance times compliance. The way you typically can think of it is one time constant is defined as the time necessary to fill 63% of the maximal inflation or deflation of the lung. Well, that doesn't sound very intuitive, but if you imagine completely inflating or deflating the lung, one time constant would be if you inflate a lung to 63% of its potential. or deflate a fully inflated lung by 63%. So it makes a little bit more sense visually. So this is, if you imagine this is a lung's potential inflation, and you get out here and you're 99% of what the lung potentially could be inflated. So one time constant is 63% of that lung's maximal volume. 2 time constants is 86%, 3, 95, 4, 98, 5 is 99%. So most people would say that it takes 5 time constants to fully inflate or deflate a lung. So here it is in math. When we do the math, these are values from previous slides that I showed you. So a time constant in a normal lung is 0.12 seconds. And I just told you it takes 5 time constants to fully inflate or deflate a lung. So in a normal healthy lung, it takes about 0.6 seconds to fully inflate or deflate a lung. So 5 time constants in a healthy infant. Well, what if you have a baby with RDS? Its time constant, when you do the math, is actually much lower. Again, we said for complete equilibration or inflation or deflation of the lung, it actually takes 5 time constants, so 5 times 0.05, 0.25 seconds. So a baby with RDS has much stiffer lungs, so those lungs inflate, deflate pretty rapidly. And that sometimes gets confusing to people. So the way I think about it is if you try to inflate a stiff cardboard box versus inflating like a rubber water bottle, you know those old-time rubber water bottles that people would put like warm water in? If you tried to inflate the water bottle that was rubber, it would take longer to deflate than inflate because it's more compliant, it's more stretchy. With a cardboard box, you could rapidly push air and suck air out of because it's stiff. So lungs with decreased compliance, like babies with RDS, will complete inflation and deflation quicker. So time constant becomes critical when the inspiratory time or expiratory time is so short that it is insufficient for pressure equilibration. So if the inspiratory time is too short, meaning less than 5 time constants, incomplete tidal volume may be delivered. If the expiratory time is too short, less than 5 time constants, then you might have incomplete expiration, increased FRC, and inadvertent PEEP. So again, I want to introduce this concept of the time constant to you because if you want to understand some of the manipulations that we do with some of our babies with severe BPD, time constant really becomes much more important to know about. So hopefully later when you hear about those patients, you'll have at least heard what a time constant is here. So what determines carbon dioxide elimination in our patients? So many people would answer that question with minute ventilation. I prefer the term alveolar ventilation over minute ventilation. Some people use alveolar ventilation and minute ventilation synonymously, even though they're slightly different. So alveolar ventilation is your tidal volume minus the dead space times the baby's respiratory rate, or some people will say your IMV in place of rate. And that's just because they're thinking of a patient on a ventilator essentially. So different ventilator types. Basically, to keep it quite simple, and we're not talking about high frequency ventilators, that's a whole nother talk. But with conventional mechanical ventilators, we have volume ventilators and pressure ventilators. So with volume ventilators, the delivered tidal volume is what you set, and the pressure is going to vary. With a pressure time-limited ventilator, the delivered pressure is what you set. And the tidal volume is going to vary, and that depends on the baby's lung compliance and the pressure gradient. So the pressure gradient is basically the difference between your PIP and your PEEP, or what some people would call the delta. So when some people talk about a ventilator, they'll say the delta. If your PEEP is 10, let's say, and your PIP is 20, so 20 over 10, your delta would be 10. Or if your PIP was 20 and your PEEP was 5, your delta would be 15. So some people will say the delta, so just be aware if you hear that term. Well, why were pressure time limited ventilators used in the NICU? Well, because back when ventilators were started, early attempts to control volume were not very effective. We didn't have very good technology, and babies didn't do very well on volume modes. And pressure limited modes are still used because they're simple and they can ventilate despite a large endotracheal tube leak. Remember, we don't use cuff tubes in most of our patients because you can do a lot of mucosal injury to the trachea with cuff tubes and tiny babies that weigh 500, 600, 700 grams. Pressure ventilation can also improve intrapulmonary gas distribution. The danger with pressure limited ventilation is that the tidal volume can vary as the baby's compliance changes, and that can lead to large volumes that are too large and potentially hyperventilation and volume trauma. So an example there is, let's say you have a baby with respiratory distress syndrome who has low compliance and they're on a pressure mode, and you give them surfactant, all of a sudden their compliance increases and they start having really big breaths, and you don't turn your pressure down and you just kind of go off and doing whatever you're doing, the baby might sustain a lot of lung injury. So that would be an argument for a volume mode. So intermittent mandatory ventilation, or some people would say that that's the rate. Changes in your rate will substantially alter alveolar ventilation and thus your PaCO2, your CO2 on your blood gas. Because remember, carbon dioxide elimination is your ventilator rate times your tidal volume minus the dead space. So the other important thing to consider about CO2 elimination is that the baby, we want the baby to spontaneously breathe the majority of the time. And that's going to contribute to the baby's overall alveolar ventilation. When you get to moderately high frequencies of breaths, or 60 breaths a minute, that using higher breath rates, higher ventilator rates, that's allowed us to use lower PIPs in the NICU. And that's helped reduce the incidence of pneumothorax. When you get to higher and higher ventilator rates, you have to watch your I time, your inspiratory time, to avoid, because if you don't lower your inspiratory time, what can happen is the baby doesn't have enough time to exhale and you can get gas trapping. So most people don't go too much higher than 50, 60 breaths per minute anymore. And actually, if you do mathematics, when the respiratory rate starts getting into the 70s, you start to lose efficiency with your minute ventilation. So rarely will you see people going up to ventilator rates in the 70s. But before high frequency ventilation, when people didn't have oscillators and jets, they would often turn their I time down to really small numbers like 0.15 or 0.2, and they might turn the ventilator rate up to 65 or 70. So they didn't have a choice. So what other than FiO2 determines oxygenation? Mean airway pressure. So mean airway pressure is the average pressure to which the lungs are exposed to during the respiratory cycle. Another way to think of that is that mean airway pressure is the area under the pressure curve divided by the duration of the cycle. So the next couple of slides are probably the most important slides for you to pay attention to. If you're going to doze off, try to wake up for a second. So mean airway pressure, one way to think of it is it's the area under the curve. So if you think of this as one breath, this is your inspiratory time. The breath starts, you have a inhalation, you reach your peak inspiratory pressure for a while. This duration that the breath is held at this peak inspiratory pressure is your inspiratory time, and then you exhale. So this is one breath. Well, if you did calculus and you quantified this number, this area under the curve, this would be your mean airway pressure. So again, let's say this is our pressure, let's say this is 0. The start of the breath is our PEEP, our peak inspiratory pressure right here. This is our PIP, which is at 20, our peak inspiratory pressure. How long we hold the breath at that peak inspiratory pressure is our I time. And then we have all this time to exhale, the expiratory time, before our next breath starts. So what are different ways that you could increase the area under the curve, or the mean airway pressure? Well, you could increase the PIP. That's going to give you a little more area under the curve. You could increase the PEEP. You could increase the inspiratory time. You could increase the flow rate. Now, that's not something that we talk about a lot in the NICU on rounds, but the respiratory therapists usually handle that and kind of take care of that for us. But you could, in other words, you could shoot the gas into the lung quicker so that you reach your PIP faster. And then one thing I didn't show on this slide is there's a fifth way you can increase mean airway pressure, and that is if you gave more breaths per unit time. So instead of, let's say our unit time is from here to here, instead of giving one breath, we gave 2. Okay? So those are the different ways you can increase the mean airway pressure. Very important concepts. Now, mathematically, sometimes when I give this talk, I make people do the math. I'm going to save you that pain. But there is this mean airway pressure equation, and this K is a constant variable, which I don't remember the number for. But the equation is that constant times your peak inspiratory pressure minus your PEEP times your inspiratory time divided by your inspiratory time. I think that's supposed to be a plus. Anyways, this is the equation. This is my simplified equation. It's not mine, but a simplified version. Your PIP times your I time over your I time plus your E time plus your PEEP times your expiratory time over your I time plus your E time. Now, residents and fellows sometimes get made to calculate this stuff out. The modern day ventilators do this for you. So if you go to the Avia, or the ventilator that we typically use here at Methodist Women's Hospital, you can click on the screen and it does that math for you. You can look at it. In fact, we often do that, especially when we're switching from an oscillator to a conventional or vice versa. We'll look at the mean airway pressure number, at least I will. So we're going to go through some scenarios, and I'll do the math for you. the point here is to look at what happens to the mean airway pressure when we change the ventilator settings. So suppose we have initial ventilator settings, we have a rate of 30, an inspiratory time of 0.5, our PIP is 20, and our PEEP is 4. So pretty common settings. What is the mean airway pressure? Well, you do the math, and again, I'm using this equation here. This is the equation we're using. And you get 8, mean airway pressure of 8 centimeters of water pressure. Well, suppose you have a gas, 7.22, BCO2 of 55, and you say, I don't like that CO2, I want to drive it down a little bit further. So what I'm going to do is I'm going to increase my PIP. What'll that do? That'll make my delta, my tidal volume, bigger, right? Well, what's that going to do to your mean airway pressure? Well, if you do the math, everything else is the same, right? Your I time, your expiratory time, your PEEP, everything's the same. All you changed was your PIP from 20 to 22. Your mean airway pressure went up a little bit to 8.5. Well, what if you chose, instead of going up on your PIP, you went up on your PEEP to 6? What would that do to the mean airway pressure? Again, everything else is constant from this first scenario, every single number except your PEEP, and you went up to 9.5. So what's the lesson here? The lesson here is increasing PEEP is more effective than increasing your PIP in terms of improving your mean airway pressure. I mean, it's math. There's no argument. So don't be a peepophobe. So a lot of times we'll have a baby who is on a lot of oxygen. Their gas has a high CO2, and will just go up on the PEEP, and you can a lot of times get a lot better oxygenation. Okay, another law here, Laplace's law. Again, not trying to put you to sleep. This is another important concept to understand, and this has to do with opening pressure. So you may hear respiratory therapists and doctors say, well, it takes more pressure to open the lung than it does to keep the lung open. This is why. So if you look at this cartoon of this alveolus, here's an airway that splits. Here's an alveolus with a larger radius and a smaller radius. So air is going to take the path of least resistance. So if it had a choice of going to one of these two alveoli, it would go to this one with a bigger radius. And it has to do with this law. Pressure to open the alveolus is equal to 2 times the surface tension over the radius. So they did some math down here to compare. So if you look at just in this example, they have this radius that's twice as long as the one on the other side, and they do the math, and everything else is held constant other than the radius. It takes a pressure of 100 versus 50 in this scenario to open this alveolus. So the alveolus that's half as small takes twice as much pressure to open it up. Now, what do we do in the NICU? We don't just deal with the R. We also deal with the surface tension by giving surfactant. So we can lessen the pressure by giving surfactant. So we affect the top, the numerator part of the equation as well. It's also important to know this diagram, because once you get the lung inflated and opened up, then what you can often we'll see is that we back down on the pressure that we're using to help the baby ventilate, right? So we have to use a lot of pressure to get the lungs opened, but because of this equation, we know once they're open, we can use less pressure to keep them open. And many of our babies have lungs that look like this. We might have one alveolus that's kind of closed and one that is opened up. So we can have babies that have lots of different alveolus, and some of them are open, some of them are closed. And so it's important to know that different alveoli might have different opening pressures throughout a lung. This is just an important quote, I think. I don't know why I threw this in here. So, we don't know everything, and, medicine is called the practice of medicine for a reason, because it's constantly changing and evolving, and, doctors certainly don't know everything. In fact, a lot of if you look at medical literature that was established as medical fact, as time goes forward, a decreasing percentage of that medical literature remains to be true over time. So like 80% of all medical findings have subsequently been proven to be false, is what it amounts to. Only about 20% remains true. So someone that has experience doesn't necessarily mean they're right. It may mean that they have the ability to make the same mistake repeatedly with increasing confidence. So question everything is what I'm trying to tell you here. Just do it politely. Okay, so what gives you the most bang for your buck? In terms of increasing PaO2 or oxygenation, your PEEP is the most effective, followed by your PIP, followed by the I time. And I could go through all the math again, or you can just take my word for it, but I showed you a couple of these. But PEEP is the most effective, followed by PIP, followed by inspiratory time. And it just so happens that the reverse is true in terms of lung injury. Your inspiratory time is the most injurious to the lung, followed by your PIP, and PEEP is the least injurious. Okay, some more scenarios to go through. So in this case, we have our same initial settings, and we calculated our MAP, which is still 8. And in this case, our CO2 was 55, and we decided we're going to increase the ventilator rate to try to drive down the carbon dioxide level. And my question is, what is that going to do to the MAP? Now, remember we talked about when you get higher rates, you need to drop your inspiratory time, or you're going to get inadvertent mean airway pressure. So what happens in this case? We turn our rate up to 60, and again, that's to decrease our CO2, but we're going to affect oxygenation, and I want to know how. And again, we dropped our I time to 0.35. So in this case, we have to change a couple of these numbers in the equation. We changed our inspiratory time to 0.35 and our expiratory time to 0.65. And look what what happened to our MAP. Went up to 9.6. So what's the point of this? You could get a blood gas and you're like not even thinking about what you're doing with oxygenation. You're just trying to get your CO2 down. And if you don't pay attention, you might have gone up on your mean airway pressure, and the baby may have not needed it. So you have to be aware that every time you change a parameter on a conventional ventilator, you can simultaneously, almost every time, be affecting both oxygenation and ventilation. So you have to really understand that mean airway pressure graph I showed you, and the delta, the change between PIP and PEEP, because these things are connected. Again, remember to lower the inspiratory time at rates greater than 40. If you did not lower your I time, like we did here, we left the I time the same, 0.5, then that would mean our inspiratory time with that high rate is only going to be 0.5. Look what it does to our mean airway pressure. So if we didn't remember to decrease our inspiratory time to 0.35, we would have a massive increase in our mean airway pressure, which you probably did not intend to do. So what's the problem with high mean airway pressure? High mean airway pressure can cause overdistension of the alveoli, leading to right to left interparenchymal shunting. You can also have mean airway pressure that gets transmitted to the intrathoracic structures, and that's inversely related to lung compliance. So if you have a baby with respiratory distress syndrome, they have low lung compliance, and you turn the mean airway pressure up, that mean airway pressure gets transmitted where? To the heart. And that can impede your cardiac output. So when you have a baby on the oscillator, this becomes really obvious because you're just changing one number, right? Mean airway pressure, you turn it up, and if you turn it up high enough, sometimes the baby's small enough and you can impede their cardiac output. And if you impede cardiac output, that can influence oxygen delivery. Do you guys want to do a break real quick? Want me to keep going? I know it's a lot of stuff.
Take a quick break.
Okay. Let's do 5. Is it? Are you guys finding this information helpful?
Yeah.
This stuff you all do before? Yeah, you probably don't.
What was that?
You probably know all this before.
When do you start?
So I gotta tell you, I really think all the nurses need to hear this stuff. I don't know what you guys think. Do you think most of your peers understand all this?
No.
I think it should be a part of the training, like before you get training.
Linda and I are already in it.
Yeah, I feel like it's good, and I feel like sometimes you go so long without talking things.
Yeah.
It's reorienting.
Is it too complex?
It's a lot.
It's
I
a
mean,
lot.
It's a lot. Like I get it, but it's hard to wrap my brain around.
Do you guys think this is too complex? Did you know all this stuff, Laura?
Do I know all of this
Yeah.
stuff? Probably not. I feel like you sent this out in an email, this like PowerPoint, and so I remember scrolling through it and seeing some of this stuff because honestly, so since I have read that slide, it's like, don't be a PPO, don't be a PPO, and that is like what I'm like, no, we'll probably change the PEEP, and we do. But before this, probably half of this stuff.
Yeah, I don't think if you don't understand these concepts, then you probably don't understand how to ventilate a patient.
I mean, I'm not sure I could tell you like all the like underlying
Like
what
the
it's doing
math
to the blood.
No, I don't expect you to know the math. But it's important to know the trend, like the trends. Like, oh, if I turn this up, this will happen.
I think it takes experience. I think it takes time to see how it affects each baby and what you're doing to a 23 acre compared to a 31 acre on that. And if they have PPH ahead.
Is that everybody? Okay. All right, well,
Believe it or not, there's a ton more. So I want to move on to this, another important concept, ventilation perfusion matching. So we have to have air going into the alveolus, but we also have to get blood flow to and from the alveolus in order for carbon dioxide to get removed from the body and oxygen to get put into the body. So we want to have adequate blood flow to the alveolus and adequate inflation of the alveolus. Both are crucial. And if you don't have both, you're not going to have optimal ventilation. So this diagram, this basically has two problem scenarios and then one good one. So this one over here is the Goldilocks situation, where you have adequate ventilation and adequate perfusion. So the alveolus is optimally inflated and there's good blood flow to it. And so the deoxygenated blood comes in and it leaves, the blood flow leaves the alveolus with oxygenated blood. Okay, so this is matched ventilation and perfusion. So you can have mismatched ventilation and perfusion if you have an under inflated alveolus. So this situation on the far left, an alveolus is not very well inflated. There's adequate blood flow, but since it's not inflated, they can't get oxygen into the blood. And so what happens is the deoxygenated blood, where's my arrow? So deoxygenated blood comes in, the alveolus is not adequately inflated, so oxygen doesn't get put into the blood, and it leaves still hypoxemic. So this is what we call intraparenchymal shunting. So sometimes you'll hear doctors talk about, oh, there's intraparenchymal shunting. This is just like a right to left shunt in the heart, right? The second situation is when you have an overdistended alveolus, so there's too much air in there, and it actually can impede blood flow. So in this situation, you have good recruitment of the alveolus, but the blood flow is poor, perhaps because of overdistension, and you have hypoxemia persisting. So we really want to be in this Goldilocks range, not underinflated, not overinflated. So what constitutes adequate oxygenation? Adequate oxygenation is the balance between the rate of oxygen delivery to the tissues and the rate of oxygen consumption. And it's important to know that your PaO2 on your blood gas may not necessarily be a good indicator of oxygenation. In fact, it might be a poor indicator. Well, why is that? Sorry, more mathematical equations. But there's the reasons I keep showing you these are totally applicable to our patients. So oxygen delivery is this long equation. This is oxygen delivery. That's what DO2 stands for. So it's cardiac output. That's not carbon monoxide. Cardiac output times your hemoglobin times your oxygen saturation times 1.37 plus PaO2 times 0.00031. Okay, so your PaO2, let's say your PaO2 on your blood gas is 80. 80 times 0.0031. That is not a large impact on what this number is. Clearly your cardiac output is, and your hemoglobin concentration or hematocrit is. But your PaO2 on your gas, pretty low yield. So all these things affect oxygen delivery. Your cardiac output, your hemoglobin concentration, your saturation, also the efficiency with which oxygen is unloaded from hemoglobin to the tissues. So remember fetal hemoglobin holds on to oxygen more than adult hemoglobin. So again, this PaO2 number on your blood gas may be normal, but that doesn't necessarily mean your oxygen delivery to your tissues is normal, because you may have all these other things going on: anemia, hypovolemia, some sort of abnormal hemoglobin, or decreased cardiac output. So all of those other things can influence your oxygen delivery, not just what's on your blood gas. All right, so we talked about, I'm trying to get some repetition now so that some of these concepts stick in your head. So ventilation, a lot of people will use CO2 elimination and ventilation synonymously. So it gets confusing to people that aren't around ventilators a lot. Sometimes when we say the patient needs to be ventilated, we mean they need to be intubated and placed on a mechanical ventilator. Sometimes when we say the patient isn't ventilating, we mean their carbon dioxide is too high. So a lot of times people will use ventilation synonymously with CO2 elimination. And again, minute ventilation is tidal volume times respiratory rate. That's what influences your CO2. The better definition is called alveolar ventilation, which is tidal volume minus the dead space times the respiratory rate. And then why do we say that? Because we really only care about the alveolus, the air, the space under the airway pressure curve that is participating in gas exchange. We care about areas that are participating in gas exchange. A lot of your lung tree does not participate in gas exchange. So your main stem bronchi, your trachea, there's no air exchanging units in there. And there can be lots of types of dead space. So you can have dead space in your endotracheal tube. You can have dead space in some of the airway tree, like your main bronchi. You can have an alveolus that isn't participating in a gas exchange. We just went through this scenario here, right? So this alveolus isn't really participating in a gas exchange. So there's lots of types of dead space. And again, why am I showing you this equipment dead space? Because the respiratory therapist will shorten the length of the endotracheal tube to decrease the airway resistance. Remember that Poiseuille's law that we talked about? But it also is decreasing the dead space. So cutting that endotracheal tube, shorten it down, decreases the airway resistance, and decreases the dead space. So this alveolar capillary membrane, that is really the gas exchanging unit that keeps us all alive. It's why we're all sitting here breathing comfortably. And basically we have deoxygenated blood coming towards the alveolus. Carbon dioxide leaves the red blood cells. Oxygen comes in, and it has to cross this membrane. So here's kind of the airway tree. There's a bunch of alveoli. If you look at this close up, okay, here's the capillary, here's the alveolus. So there's air in here, blood in here, deoxygenated blood, oxygen comes in, carbon dioxide goes out, and you get your oxygenated blood. So this is the membrane across which the gas has to diffuse. So remember that very first slide I showed you, the BPD, this membrane gets thickened. It's harder for the gas to diffuse across it. And there's lots of important cells here. There's these type 1 pneumatocytes or type 1 alveoli, or alveolar cells. Then there's a capillary basement membrane, an endothelial basement membrane, and endothelial cells. So this alveolar capillary membrane is crucial to our patients, especially the ones that develop BPD. So that's what we're trying to minimize injury at this level. So common scenario, you have an infant that you weaned from a rate of 25 to 20. And the baby had a previous excellent blood gas, 736/36/80. 1 hour later, you get a follow-up blood gas, and now your gas is 721/60/60. And all you did was take your rate from 25 to 20. What should you do? Should you go back up to a rate of 25? Probably you should get an x-ray, because probably you have some sort of mechanical issue. You have a blocked tube or a pneumothorax or a right main stem. It would be highly unlikely for a baby that's weaning with this excellent gas to go all the way from a CO2 of 36 to 60 in 1 hour with a rate change of 25 to 20. And probably the baby spontaneously breathing over the ventilator as well. That's a little bit of a trick question for you. Residents fall for this all the time. So residents get this. This happens to residents all the time. This is really a talk for residents. They make that mistake a lot, including me when I was a resident. So we like to think that our lungs look like this, with lots of alveoli for gas exchange. But preemies' lungs really look like this. So their lungs are not very well developed. The alveoli are not complex and mature. Haven't really formed yet. They have insufficient surfactant. The terminal bronchioles are probably the most compliant structures in premature lungs and the most vulnerable to injury. So we apply positive pressure to the lungs and we envision that scenario, but what really happens is this. Okay? And if you're unlucky, you get an air leak. What happens when you get an air leak? Well, air leaks can be lots of different things. They can be a pneumothorax. Okay, there's free air in the pleural space. You can get pulmonary interstitial emphysema. Kind of looks like salt and pepper or little bubbles over here. If you had a gross pathologic specimen of the lung, you would see all these little bubbles. I like to think of PIE, or pulmonary interstitial emphysema, as a pneumothorax within the lung. That's really what it is. The air escapes into the lung parenchyma. It just hasn't coalesced and escaped into the pleural space. Now sometimes all these little bubbles will coalesce, and then you get a pneumothorax. So when we have a baby with PIE, we know they're at high risk for pneumothorax because they've already basically had a pneumothorax at the microscopic level. The air is just kind of trapped within the parenchyma for a while. So what do we do to treat those situations? Well, you want to ventilate the lung below the threshold at which the air leak occurred. So if you think of it as there's some threshold above which the lung pops that open, that little hole. You want to try to ventilate the baby. When I mean ventilate, I mean help the baby breathe below that threshold. So this is a cartoon trying to demonstrate that fact. This is a conventional mechanical ventilator breath, and you can see what they're trying to show here is that the area above that threshold, in this case they're using about a PIP at 25, that's the area above the threshold. So you can imagine if you had a baby with a pneumothorax or PIE, that's a lot of time above that threshold. You might not be allowing that air leak to heal if you keep ventilating at that high of pressure. So the idea with high frequency ventilation is to try to use much smaller, shorter breaths and reduce this time. So this is high frequency jet ventilator, and they're just trying to show with these breaths that you're getting a lot less time below that threshold. Does that make sense? Part of the reason that we often flip babies with PIE or pneumothoraces to high frequency oscillation is because of this concept. And if you had a baby with an air leak syndrome and you wanted to increase something to try to prevent atelectasis, if your air leak occurred at these terminal bronchioles, which is what I showed you back here. So again, remember we're envisioning that that's what happens when we give a breath, but really it's more like this in our tiny babies. And then they get the air leak right there. So if you're trying to ventilate, you can actually turn your PEEP up, get this alveoli bigger, see, this one compared to this one, and still perhaps not affect the air leak all that much as opposed to going up on your PIP. So why am I telling you all these things? You can do damage with any ventilator if you use it incorrectly. So this is a quote that I like to talk about in respiratory talks. It's the carpenter, not the tool. So this was written back in 1965, before I was born. The tedious argument about the virtues of respirators not invented over those readily available can be ended now that it is abundantly clear that the success of such apparatus depends on the skills with which they are used. So you may hear me say, well, I don't really, we can use the oscillator, we can use the conventional ventilator. It's as important that you know how to use the tool as it is which tool you use. So some people will go back and forth like, we need to be on this ventilator, we need to be on that ventilator. And I would say, well, number one, you need to use whatever ventilator you're using correctly and optimally. The next level of questions might be, should we be on the oscillator or the conventional ventilator? So you have to use your tool appropriately. This was where we were going to break originally, but I stopped earlier. Okay, so far we've talked about preventing prematurity with marchadimes, antenatal steroids. We talked about some of these mechanical ventilator issues. Again, this is our slide about different strategies to prevent BPD. So oxygen toxicity. Premature babies have immature antioxidant defenses. And there have been many studies over the years, too many to summarize in this talk, but trying to look at the exact oxygen saturation target that we should give preemies. Currently, babies that are less than 28 weeks, we target them 90 to 95%. And when people have tried to do lower oxygen targets, the good thing is they found a decrease in retinopathy of prematurity. The bad thing is more babies died and they got more neck. So this has been extensively studied and will continue to be studied. But right now, we use 90 to 95. That may change. It's changed about 3 times in my career. All right, so we talked a little bit about mechanical ventilation, but what we really do the majority of the time now in the NICU is non-invasive ventilation, meaning ventilation without an endotracheal tube. So that's how I define non-invasive ventilation. Assisted ventilation or respiratory support without an endotracheal tube. We do this all the time. It's rare that we have 10 kids on ventilators. When I started my residency in med school, and NICUs had tons of kids on ventilators. And now we have tons of kids on CPAP or nasal INV. We might have 2 or 3 on a ventilator. And that's the norm now. And that's the way it is in the majority of places around the country. So what we really do is non-invasive ventilation now. That's what we've evolved into. There's lots of different types of non-invasive ventilation, lots of different terms to be aware of. There's nasal intermittent positive pressure ventilation or nasal intermittent mandatory ventilation. Some people will call it cycled nasal CPAP. There's also SNIPPV, which the S stands for synchronized nasal intermittent positive pressure ventilation. And there's nasal CPAP or face mask CPAP. We also have high flow nasal cannula, or the preferred term, triple H, heated humidified high flow nasal cannula, triple H. We also have low flow nasal cannula, or some people will just call it nasal cannula. And then we also have the oxy hood, which some of you may never have even seen. Maggie probably has never seen that. So it's also called a head box because it's, well, I'm older than you. So
Not that much older.
some people call it a head box because it kind of looks like it's a box that goes over your head. So these are all the ways that I know of, or terms I know of. I'm probably missing some for non-invasive ventilation. The key, the baby has to be breathing spontaneously to do any of these. So mechanical ventilation is life-saving, but it can have unwanted effects. We know that invasive mechanical ventilation increases the risk of BPD, and prolonged mechanical ventilation is associated with the likelihood of worsening neurodevelopmental outcomes. Complications of endotracheal tubes, well, there's a lot. They can be traumatic and painful. You can have hemodynamic instability, infections. There's a higher risk of late onset sepsis with being mechanically intubated and ventilated. Ventilator-associated pneumonia, airway emergencies. This is my big fear of being intubated myself, is that I'll have a, clogged endotracheal tube or a malaligned endotracheal tube that goes down the right main stem, and you were fine 1 minute, and then the next minute you have, your pH is 6.8 and no one discovers it. So when people argue that let's just leave the baby intubated another day, that's a big deal, right? I mean, that's 24 hours where at any moment their tube could get clogged or malaligned, malpositioned. So just be aware when you say that, oh, let's just leave the baby intubated. Maybe that's the right decision, but maybe you should think about extubation if you can. What about air leaks? I just showed you pneumothorax and PIE, more likely if you have an endotracheal tube. And then there's permanent airway lesions. So what do I mean by permanent airway lesions? Well, you probably all heard of the term subglottic stenosis. So when you have that endotracheal tube in the trachea, the mucosa is going to react. especially if the baby's moving around. Okay, so you might get edema and scarring, and sometimes it's minimal, but it can get worse and worse, and it can get to where it almost completely or completely occludes the airway. Okay, so this is why sometimes we give steroids before extubation to kids that have been chronically ventilated with an endotracheal tube to try to decrease that edema, because we pull that tube out and then they're trying to breathe through maybe a tiny hole. Sometimes these kids have to have surgery. Ventilator-induced lung injury, also called ventilator-associated lung injury. There's lots of different terms that you probably have heard. The most important one is volutrauma. That's the main culprit to lung injury, is volutrauma. But barotrauma is damage caused by pressure. Volutrauma is trauma to the lung caused by overdistension or excessive stretch. You can have biotrauma. That's disruption of the alveolar capillary membrane and the small airway epithelium, and that results in edema and inflammation, release of inflammatory cytokines. Atelectotrauma. So that's damage caused by tidal ventilation at suboptimal alveolar inflation or in the presence of atelectasis. And then there's this term called RACE, repeated alveolar collapse and expansion. So that's also not good. There's all these different ways we can injure the lung when we're ventilating patients. So Alan Jobe, he's probably one of the top 5 most respected neonatologists on earth. He's certainly one of the most studied, if not the most studied person in terms of respiratory diseases in neonates. And he says, perhaps the only consensus about mechanical ventilation of infants is that, all else being equal, avoidance of mechanical ventilation is the best way to avoid lung injury. So this is kind of how I think of mechanical ventilators. The ventilator is the alligator, and the babies are kind of like that frog. So we have to be very, very gentle. And if possible, get rid of the endotracheal tube. So how does CPAP, which I'm also calling the stenting pressure, help? It improves volume recruitment and maintenance. It avoids atelectasis, stabilizes the chest wall, which is extremely important in some of our tiny kids who sometimes have relatively minimal lung disease, but their lungs have a tendency to want to collapse because the chest wall wants to kind of collapse down. So the CPAP helps kind of stent things open. And that can decrease their work of breathing, improving the ventilation and perfusion mismatching that we talked about by keeping the alveolus optimally inflated. Reduces airway resistance, right? We stent the airway open, that widens the diameter. We talked about Laplace's law and Poussil's law. And now you know the math behind it. So lots of ways CPAP helps. So again, back to, this is a slightly different diagram, but the concept's the same. We want to be in this optimal inflation target. We don't want to be underinflated or overinflated. Optimal inflation facilitates both oxygenation and CO2 elimination. So we want to be in that perfect VQ matching zone, or like I call it, the Goldilocks zone. So what about pulmonary edema? Sometimes we'll have kids that have, we think they have a little bit more fluid in this interstitial space. That's supposed to be represented here. You might be able to get them to oxygenate a little bit better by increasing your PEEP, making the alveolus a little bit more inflated. The idea is that you're kind of displacing some of that interstitial water. Okay, 2 concepts about nasal CPAP you need to know. How the CPAP is generated, or how the air moves, and then how the device interfaces with the patient. So this is a simplified diagram, but it basically summarizes how all CPAP devices work. This happens to be bubble CPAP device, which isn't important. What is important is that you have an oxygen source and a pressure source that creates pressure here. You have this long tube, so that oxygen and pressure is going through here. It goes across the patient. So this part right here is the patient interface. And then the air continues and goes to this expiratory valve. So this expiratory valve is where you control the pressure. So if you have bubble CPAP, you can just lower or raise the tube's level in the water, and that changes the water pressure. With a machine, you just turn the knob. But the important point is there's an inspiratory limb and an expiratory limb, and then there's this patient interface. So again, I've showed you some of these diagrams, but the way CPAP works basically is that with normal breathing, you have your tidal volume superimposed over some level of distending pressure. And with CPAP, you're basically raising the distending pressure. You still have to have the tidal ventilation superimposed over that. When babies grunt, they're basically, what they're doing is if their vocal cords are like this, they're narrowing them, right? That increases the resistance. It's almost like turning up the expiratory resistance valve on the CPAP circuit. So they're increasing their PEEP by making that grunting sound. With their vocal cords, they're exhaling against a partially closed glottis. It does the same thing as we do with CPAP. Does that make sense? So what the baby is doing with their vocal cords, they're kind of adjusting the expiratory limb. Does that make sense? Patient interfaces. These are a real pain in the butt. There's lots of them. Most of them are difficult to manage, and that's where nurses come in. There's masks and there's nasal prongs. There's infant flow prongs. This is an example of the infant flow device some of you may have used in your career. There's different sizes. Here's the Hudson prongs, which some people think are the greatest thing ever. This is what they use in Colombia, I believe, which is the supposedly the best place on the planet for non-invasive ventilation. There's Argyle prongs, there's Inca prongs, they have masks as well. AirLife prongs, you can go on and on with these. So how does CPAP really work? CPAP works with vigilant, excellent nursing care. Doctors and respiratory therapists cannot be in the room, are not in the room as much as nurses are. And the way that CPAP works is it has to be perfectly positioned at all times. Improperly positioned nasal CPAP prongs should be thought of the same way as a baby that has an improperly positioned endotracheal tube. Both devices, an endotracheal tube and CPAP, are providing distending pressure. So if you had a baby that was on 80% oxygen, super high ventilator settings, and weighed 600 grams, and that baby rapidly extubated and started desatting into the 40s, you would react right away. That would be an emergency. CPAP should be thought of the same way. If the baby's CPAP prongs are out, that baby's losing its distending pressure. And think about if that was a baby that took 4 weeks to get off the ventilator, and now you've just lost all their functional residual capacity. That's a major, major thing in that baby's life. So improperly positioned CPAP prongs should be thought of as an emergency. The RAM cannula. This is what we use at Methodist Women's Hospital. It's got a narrow diameter of the cannula, and that allows the airflow to be generated as a jet. And the thought is that it achieves a more efficient penetration of the nasopharyngeal pathway, reducing nasal dead space. If you think about resistance to airflow and dead space, about 50% of work of breathing in a non-intubated patient all happens up in here. And so the idea with the RAM cannula is that this jet flow of air is reducing the dead space. It's got a simple design. It seems to be well tolerated. It's not very intrusive compared to some of the other devices I showed you. I think it's better for development. It's got an inspiratory limb and an expiratory limb. And you can use it with nasal CPAP or nasal IMV. And you might correct me if I'm wrong, Alexa, but I think there's 4 different sizes.
Actually,
There's 5 now.
we got the big one for
Yeah, so
the latest.
you can use it on lots of size babies. So this is Dr. Ramanathan. He helped design it. This is what it looks like. It looks, if you were a novice or not paying attention, it would look just like a nasal cannula, but it's actually delivering CPAP. So anytime we have a new therapy that we introduce of any kind, whether it's a medication or a ventilator, always be aware that sometimes complications just haven't come to light yet. So it could be that, 20 years from now, people are saying, why did you guys use that RAM cannula? Well, we didn't know. Something that is going to be discovered, right? Chin straps. Some of you get mad at me when I talk about chin straps. Why do I talk about chin straps? So this is a baby that has kind of a ad lib piece of tape to keep its mouth closed. So here's why. This is a baby getting nasal CPAP. Gray bars are mouth closed. Lighter bars are mouth open. There's a massive difference in the distending pressure. Okay, so it's actually been studied and proven that the chin straps work.
People don't like chin straps.
Some people don't like chin straps. I like chin straps. So what about high flow nasal cannula? People looked at whether or not the mouth was open or closed with a high flow nasal cannula, and this study, no difference on high flow nasal cannula, but there was a difference with CPAP. High flow nasal cannula, I'm not a huge fan of ever since the RAM cannula came out. The 2 main brands are Vapotherm and Fisher-Paykel. The problem with high flow nasal cannula is that there's no expiratory limb. Remember I showed you back here, somewhere, they have this expiratory limb. We control the pressure that is going across this patient interface. So we know how much pressure is getting delivered to the baby. With high flow nasal cannula, we don't know exactly how much, and we can't regulate it. So the flow of gas is monophasic, and the delivered pressure is dependent on the patient leak. So if the infant closes their mouth and the cannula are sealed really well, and there's lots of secretions, or say they're too tight, the flow is just going to build up and build up and build up until it finds an exit. And that could be the baby's mouth if the mouth is open, which is probably a good thing in that situation. It could be the soft tissues, it could be the lungs, GI tract. So it's unpredictable with high pressure. So unpredictable high pressures can get transmitted to the lungs. So I'm not a big fan of high flow nasal cannula, and you probably won't see me use it hardly at all. Here are some examples of case studies of babies that have had air leaks. So here's a baby, 26-weeker, 900 grams, 2 liters per minute, 36 days old, got air tracked up all the way into its orbit, into its eye. Here's one into the scalp, okay, subcutaneous scalp. Yeah, so these things happen. They're not very common, luckily, but again, you're not able to predict or control the pressure you're delivering with high flow nasal cannula. What we do know, people have tried to study and estimate the flow, and at what flow generates what pressure is kind of what they're trying to ask. And there's a couple of different equations you can try to use to estimate them, and they all depend on the baby's weight. And the bottom line is that larger infants need more flow than smaller infants to generate the same descending pressure. So if you're a 4 kilo kid on 1 liter of high flow, you're probably not, getting a whole lot of descending pressure as compared to like a 800 grammer on 1 liter. Okay, does that make sense? So bigger babies seem to need more flow, but again, it's unpredictable. So that's a generality. But you can use these equations here to give you a ballpark of what kind of descending pressure you're delivering. So what I say about high flow is that it may be as effective as nasal CPAP in improving respiratory mechanics, but likely only at flow rates greater than 2 liters per minute. It provides inconsistent and unpredictable descending pressure that you can't measure. So I avoid using it, especially in tiny babies, and I don't like going more than a couple of liters per minute. But again, that's arbitrary. You could have a baby that 2 liters per minute isn't enough on, but you don't know. All right, now we're in pet peeve time. So this is a pet peeve of mine. People will sometimes try to make the argument that the baby's too small to be extubated. And that's been studied long ago. This happens to be studied at Wake Forest where I did my fellowship, and this person was a fellow with me. So I can speak to this study pretty well. So this study was actually comparing 2 different types of CPAP. But that's not what I care about. What I care about in this study is look at the success of extubation as a function of birth weight. So these babies, 600 to 800 grams, despite which type of CPAP they were on, were successfully extubated over 60% of the time. So if you ask yourself, well, I don't think that baby should be extubated. Well, this data would suggest the baby's got more likely chance of staying extubated than not if they were born with a weight between 600 and 800 grams. What about extubation weight? The babies still, if you look at their extubation weight, over 50% of them, so it's still at least half, if not more, had success at staying extubated. So when I look at that information, I say the baby has as good a chance, if not better, at staying off the ventilator. Why wouldn't you try them off the ventilator if you think they're ready for extubation? We already talked about all the bad things that can happen with an endotracheal tube in place, and little babies can do it. Now, when you get really, really small, it does get harder. Babies less than 600 grams, you can see the bars go down. Why do babies fail? Well, it's mostly because of apnea and bradycardia. Or if they get really high FiO2s or CO2s. But mostly apnea and bradycardia is the main reason they fell. This was a paper looking at several different studies comparing extubation failure, whether or not you use nasal IMV or CPAP. And basically over here, so ignore these bars over here, that's looking at BPD. But looking at extubation failure, the black bars are nasal CPAP, and the diagonal bars next to them are nasal IMV. Much less extubation failure with nasal IMV. So I typically, if I have a baby I'm really concerned about failing extubation, I try to extubate them to nasal IMV as opposed to nasal CPAP. Now I can tell you there's been no difference comparing nasal IMV to nasal CPAP as a primary mode of non-invasive ventilation, no difference in BPD. But if you're looking at a baby that's on the ventilator and you're trying to extubate them and keep them off the ventilator, nasal IMV seems to be more effective. So this was an important trial mentioning what looking at what I just talked about. This was published in the New England Journal of Medicine about 5 years ago. Had over 1,000 babies, less than 1,000 grams or 30 weeks of gestation, and they randomized babies to nasal IMV or CPAP at the first time they were able to be non-invasively ventilated. And their primary outcome was looking at death or BPD, and they found no difference. So again, nasal IMV versus nasal CPAP doesn't seem to affect the likelihood of BPD, but it does help you stay out the ventilator. Let's see, complications of nasal ventilation. You have to be very careful with the patient interface, all those different interfaces I showed you, because we can actually do a lot of damage. The prongs can get obstructed. The babies can hypoventilate. You can have local trauma to the skin or soft tissue, pressure necrosis. There can be pneumothoraces. Some babies will develop what we call CPAP belly, so they get too much air in their stomach. You know, ideally, we would be able to force all the air directly into the trachea and into the lungs, so that we know that some of the air is going to go into the stomach, into the GI tract. And I don't really differentiate one or any of these complications more or less with nasal CPAP or nasal IMV. So some examples. Here's transection of the nasal septum. Necrosis of the nasal septum, you can see here. I have seen this before. I don't know if any of you guys have seen this before. Some of these kids end up needing plastic surgery. I've even had babies where it was so bad that we had to intubate them because we could no longer use the nasal CPAP interface. Here's a baby that developed a notch. Flaring of the nostrils, okay. What we call pig nose. You get your nose pushed way up. Okay, you can see that this is probably not ideally positioned right there. Just see the creases in the baby's nasal bridge. More nasal snubbing. So here, there's different devices that you guys know better than me to help protect the nasal septum and the nose, and I'm happy that you guys utilize all these. Duoderm, cannulate, sticky whiskers, there's all kinds of different things. And there's a real art to this, and I hope those of you that are really good pass your expertise on to your colleagues, because I don't know this stuff, but it's really, really important. Positioning aids, again, something you guys know a lot better than me, but keeping the baby happy so they're not fighting and squirming and messing with the patient interface, very important.